welcome to the penultimate meeting of HTAG. Before I start, kei te ingoe tātou, ko tēnei karakia timata. Kia hora te marino, kia whakapauna me te moana, hei huarati mā tātou I te rangi nei, aroha atu, aroha mai, tātou I nā tātou ia tātou. We're out for the second to last time, and it's been a privilege to serve you guys. But are there any apologies to acknowledge before I go into a little wee koho? We have an apology from Brendan Duffy. Are there others? I understand that some people may have to leave during the meeting and rejoin us. That's quite okay. Just put your hand up before you leave and it'll be noted. Well, we'll move on to my little coho. Look, this is our second to last meeting of HTAG, and I wish to take the opportunity to thank the Chief Executive, Catherine, and the management team who have reported and responded to HTAG. This has been a task that is necessary for good governance, and we really appreciate the effort. But we're also a subcommittee of the District Health Board, and we're volunteers who provide governance and support that is essential to good healthcare. However, the important and necessary part of the sum are the people who rely on us and who hold us accountable. The press, kia ora Janine, and those whom we recognise for their commitment to better healthcare. And in particular, I'd like to acknowledge the continuing presence of the Hume family, that's Owen and Carrie, in memory of their daughter Erica, who died here in Palmerston North. We cannot forget this, and we should always remember these things so that we can strive to do the best job whenever we can and as the opportunity arises. To those who served HTAG and its predecessors, these are the dedicated health workers, professional staff and senior management who have supported this committee with their service and goodwill, not forgetting previous members of the committees that preceded us. That's the Quality and Excellence Advisory Committee chaired by Barbara Robson, and the Public Health Committee chaired by Diane Anderson, and ably her deputy was Barbara Cameron. Look, I haven't mentioned everyone, but I think we must reflect on the past as we go into these uncertain times. Not only the elephant in the room, which is COVID, but also with the health reforms, which are putting on additional pressures on our hospital and on our senior management team, who are trying desperately to make sure that the right resources are in the right place. So just a big mihi to Kath and her staff, and I think particularly the man on the hot spot, Kelvin. Kia ora koutou. And Stephen, look, Stephen, you're a chair of an important committee whose responsibilities will be grandparented into the future with the health reforms. And so we look to the leadership from people like you in your position to take what we've learnt into the health reforms and into what will be a new and better future for health. It's an opportunity we must grasp with both hands and relish. It's not going to be easy. But let's get on with this meeting. I understand there are no late items, so let's move on to the register of interests. Are there any new interests to be declared? If you can put your hand up, I'd appreciate that. Or nod. Okay, I gather there are none, so we'll move on. We'll move on to the minutes of the previous HTAG committee meeting, which was at November last year on the 23rd. I'll take the minutes as read. Are there any matters arising from these minutes? Great, no. Okay, thank you. Well, I'll just I'll move that these minutes be accepted. Over seconder, please. Thank you, Karen. Those in favour, raise your hand. Those saying no, raise your hand. Those are the yeses. Any noes? Thank you. I'll take these minutes as being approved. Now, just a matter of timing before we continue with the reports from the 7 directorates, that we will take a 15-minute break at 10:15. At 10:30, we'll consider the performance reports. But most importantly, we have a report at 10 o'clock. Now, we're going to be moving through the agenda quite quickly, so we might bring these forward. And I think this is just to help everyone here attending get onto other matters that may be more urgent than attending this meeting. But in the matter of good governance, we must do a good job. And so if you please don't be shy to ask questions. Thank you. Okay, we'll move on to the cluster functioning reporting, and we'll start with Scott.
Yes, Chair. So as through you, Chair, as the convener for the combined directory report, I'll just make some general comments and open it up for questions. Firstly, I guess overall, as you've noted, we have been continuing to manage the demands across the health system, both in hospital and across community, obviously whilst planning for Omicron and the expected outbreak that's now with us. We're seeing a lot of workforce pressures, across the system, but in particular, noting the pressures on public health teams around testing, vaccination, and so on. And as you can see, we have some consistent, persistent challenges in some of the KPIs. Moving through the report in terms of primary and community, just noting the ongoing challenges around enrolments and GP shortages, but also seeing that there is some recruitment coming through there, which is positive. We are having continued challenges impacting on vaccination rates, and that's really just because of the ongoing pressures on workforce around responding to COVID. With respect to screening, just noting the breast screen coast to coast have reviewed and updated their engaging with Maori wahine process with a specific focus on addressing that equity gap. Within specialist care, noting the persistent challenges we're seeing on the shorter stays in ED target, NSP5, and but also work underway in those spaces to address. And there's actually quite a lot of good work happened in the last quarter with OPAL around not only specialing but approving discharge from OPAL. Within mental health, just noting the increase in average length of stay, but that's really been driven by some long stay Maori patients who were discharged in the quarter, and also that the extended care facility that has been set up for taking those people who require long-term rehabilitation needs that are no longer acute is operational. So happy to take any questions at this point, and my colleagues will be able to assist. Thank you, Chair.
Thank you, Scott. Are there any questions from the committee? Okay, Oriana, and then...
And Jenny beat me with her hand up. I'll go after Jen.
Okay, Jenny.
Very polite of you, Oriana. Morena, Koto. Sorry, I was a few minutes late, I do want to say as well. Just literally as I was joining, had a staff member called with a big topic that's going on at the moment. So just my question, Scott, is in regards to childhood immunisations. And it's back at before this was the thing that it is now. I recall being part of different working groups where it was discussed or, brainstormed around the possibility that childhood immunisations may be available during COVID vaccinations, as in when we're seeing the whānau anyway, there'd be an opportunity to potentially do that, as deliver that service as well. I fully want to appreciate that that was before we knew it was the mammoth task that it has become. But my question just is there anywhere in the country who actually were able to do that, or did it become clear that resourcing to deliver the COVID vaccinations was all that would be possible.
Kelvin, are you able to answer that, or does anyone have any insight into the question, please?
I do know that some work was quite successful up in Tarawhiti, up in Gisborne Way, but the exact details on that I would need to look into. I'm happy to reflect that back to you and get some more details, but it's just as part of conversations and other meetings and specifics. I'm sorry, I can't add to it. It is a very challenging area across multiple fronts.
Yeah, and I don't want to add to your workload, Kelvin. I just given that was something that was discussed in fairness some time ago now, I was just interested if it had been able to eventuate anywhere. Thank you.
Got it, Jenny. Oriana.
Oh, kia ora. And my question actually, there's two things. One is around the childhood ins. 66% for Māori is terrible. But I just want to say that obviously, and it talks about it in the report about the no vax movement and all that business around COVID and vaccinations is having an effect on our immunisation rate, obviously. And I just want to share with people, we have in the Manawatu district, we have a kura, and the majority of whānau that belong to that kura are they either are no vaxxers or they are anti-vax. And a number of them have now tested positive. Yesterday we had one family turn up that are positive, and but it's not their fault. So we had a little bit of they're out in our car park and yelling at everybody inside, that they're not vaxxed, but it's not their fault that they now have COVID. And so the fallout from that I'm really worried about is the long-term effect is that they will not allow their children or their mokopuna to be immunised as we go along. And I know it's bigger than just our meeting here, but I am really concerned that that type of activity is going to lower our vaccination rates even more. And as we move into our new environment, that I don't know if anyone's got some brilliant way of getting us over that, because it's right on our doorstep. It's two of our families that have come back positive have been in Wellington. One family intends to go back once they're better and take they've got a household of 7, and this time they're taking their whole household to Wellington. So that's an example of not even being able to talk any sense to this particular whānau. But I am really, really worried that attitude is going to spread throughout the population that's most at risk. So I just wanted to share that with people. And like I said, if anyone's got any, I don't know, between all of us and our primary care partners and whoever else has got an idea about how we can work through that with our most at risk population, that would be great. And I just also want to acknowledge the role of general practice in this whole COVID business and where we're moving to and the stress that general practice is under at the moment. Kia ora, Chair.
Kia ora, Oriana. Before we go on to Heather, Jeff, have you got any advice you can add to this?
Thanks, Chair. I would hate to try and advise Oriana on how to convince Maori whānau to get vaxxed. I think it's a collective effort. The only thing we can learn from up and down the country is that finding someone who's trusted close to the family is the only answer. Anybody who's with the government or any organisation will not be trusted.
Yeah. And
that includes all of us on this Zoom. So if that's the only lesson that I have learned from Tarawhiti and Te Tokoro, is that it has to be someone close who is trusted.
Kia ora, Jeff.
I agree with you, Jeff, totally.
Heather.
Thank you, John. Of course, my question is about SB5 numbers. I'm interested to know how many people remain on waiting lists and how long they are. We had 900 at one stage. Where are we at with waiting lists for electives?
So I'm happy to give you an update, Heather. So in SB2 for first specialist assessments, in the total waiting list, we have 3,731 people on the total FSA waiting list. Of those currently, as of this morning, there is approximately 354 waiting greater than 4 months, but 245 of those have an appointment just outside of the 4-month wait time. So they do have an appointment. On SB5 for surgery, which is probably our more challenging area, given our theatre capacity and our Spire work that's ongoing, we have a total waiting list of 2,006 patients for surgery. Of those, 1,026 are waiting greater than 4 months and 92 have a booked date for surgery. And we are just completing reviewing general surgery and ENT. We've done their FSAs. We're just now moving to their surgical waiting lists and reviewing with the clinicians and phoning every patient on those lists. Yep.
How does, if I may, John, just another question. How are staff dealing with the pressure of those wait lists? I mean, obviously I know how the public are dealing with them. It's stressful, but it must equally be stressful for the people.
I think, Heather, the challenge is I suppose, knowing that those patients are waiting, and of course, some patients are contacting us and around there where they are on the wait list. And I think for staff, that's challenging, knowing what we're moving into with Omicron and our and capacity and what we can do. And of course, Omicron potentially won't be just about patients in hospital, it will be about our own staff and them becoming unwell too. And I don't think it's particular to us nationally, you know, particularly surgical waiting lists are a challenge. We are working in the central region COOs and the planned care managers in drafting up what we can do in a networked hospital sense across the central region hospitals and how we can work better together to reduce the wait lists for surgery.
Okay, thank you. I guess I get it's an awful
It's
time.
a challenge. Yeah.
Thank you.
Thank you, Lynn. Lou.
Scott, quick question. Our testing station in Main Street, I went past it yesterday and the cars were right around to Broadway, right up at Broadway to Victoria, backed up. Are we going to open a second testing station anywhere in Palmerston North?
Yes, Lou, we sent a comms out yesterday. The arena is opening from today from 11 o'clock. And we're also, we'll be running that certainly for the next 4 to 5 days.
Yeah, thank you.
Sorry, could you just clarify what will be happening at the arena, what will be happening in Main Street, Scott, please?
Essentially, we have now 2 testing sites for the interim period, so people can head to Main Street or arena. Through our comms, we're encouraging people to go to arena because of it's much better flow, it has much better capacity, and we're taking that traffic out of the centre of the city. We'll also then be able to more actively monitor the queues at Main Street and divert traffic to the arena.
Thank you, Scott.
I think, Scott, the general encouragement is for those collecting rats would go to the arena, whereas those needing PCR, we would still want to go through the site at Main. but it's hard for public to kind of differentiate those things. So I guess we'll see how that goes.
Thank you, Kath. Well, if there are no further questions, we'll go on to Duru Maitai Mationa and Sarah and Claire.
Claire sends her apologies this morning. She's actually not at work today. So I'll take the paper as read this morning. I'd like to draw your attention to the following area of the report, if that's okay. And that relates to the outreach radiation project for Hawke's Bay, which is now significantly behind the original plan to go live date due to the requirement to move the location of the bunker. The team at Hawke's Bay is working incredibly hard to progress the business case for the new location as quickly as possible, but it is going to delay the commencement of the regional project there. And also vacancies across the medical workforce in the cluster are currently being mitigated, and active recruitment is ongoing. However, there's good liaison with the Cancer Agency, wait times nationally to see if support from other centres can be offered where necessary. Happy to take any questions. Thank you.
Got it, Sarah. Are there questions for Sarah? Thank you, Sarah. We'll move on. Turu Pāharakeke. Sarah again.
Thank you. I'll take the paper as read. Just to note a couple of points. I'd like to apologise to the committee, or Jeff and I would, as we were hoping to present the results of Tungia Te Ururua this morning. We are still waiting for that final report from the independent analyser. We're hoping that it's actually going to arrive today. The outcome of this work is going to impact the development of the first 1,000 days strategy, which is highlighted in the significant matters in the report. And finally, midwifery recruitment remains complex and difficult. A robust workforce plan is in place, and a staffing escalation plan has now been approved. 3 graduates have commenced, and also our Kaiara Ara Tuora Maori midwife specialist role has commenced, which is exciting. And antenatal clinic's going to relocate to the rooms underneath the birthing centre once the building work's complete. Thank you. Happy to take
Sarah, questions for Sarah? Matiro.
Morena koutou. Tēnā koe, Sarah, Jeff. Great to see you guys. I was just, I heard you say that the survey the analysis hasn't quite been completed. I gather that they will be doing the analysis also in terms of ethnicity participation.
Yes, absolutely. And that's why, so we asked them to go back and make sure it was broken down into locality and ethnicity as well.
And if the proportion of ethnicity participation is not as we would desire it to be, have you got a step?
We did have really good Maori representation in this. So we were up at nearly 30%. I think it was 28%, Jeff, off the top of my head. So we were really pleased with that participation. Our Pacific population was less positive. So yeah, I think we'll see what comes out of it.
Cool, thank you. And just one further, just I note, which is great, that we've got somebody coming from overseas for and soon, and it's looking good. I just wondered, how do we actually support people who come from overseas to get sort of a more kind of speedier cultural cultural lens to their work, because that's actually quite a different perspective.
Yeah, I think that's really valid. So as part of the midwifery registration in New Zealand, and Selena will correct me if I'm wrong, they do have to do a cultural module as part of their registration in New Zealand. Hopefully Selena will nod now if I've got that right.
Yeah. Yes, absolutely. They have to do that cultural module before they can commence practicing here in New Zealand.
We also have a clinical coach who's Maori, and she'll be supporting her as she transitions into practice here in New Zealand, which is fantastic. And we'll be linking her in closely with our new Kaiara Ara Tuora role, so that she can also brief her about local issues, and also be doing the cultural competency training here at MidCentral as quickly as we can possibly get her on that as well.
Thank you, Sarah.
Thank you.
Kia ora, Matiro. Heather, you have your hand
Sorry,
up
I
here.
just never took my hand down. Sorry, I'll just put it down.
Thank you. Well, as there are no further questions, we'll move on to Rohi. Scott.
Morena again. I'll take the report as read and just draw your attention to a couple of points. Firstly, the RFP for the Horowhenua Acute Service is progressing, and noting that we received a response from Mopoku Tribal Authority, Raukawa Whanaora, Mana o Te Tangata Trust and Whaioro with the merge. So that's that work is going to continue. So that's very exciting. Probably in the workforce space, just noting the pressures on vacancies across services, partly an impact of you know, some changes to Te Mā Tapuna o Te Ora, where we were seeking to increase allied input into the model, but also noting ongoing challenges around recruitment of medical staff in that space. And I think we'll take the rest of the report as read and happy to answer any questions. Thank you.
Kia ora, Scott. Do we have questions for Scott? Matiro.
Kia ora, Scott. I was just wondering on page, let me see what page that is. It is page 4 of 5 under 1.3, Child and Adolescent Mental Health and Addiction Services. I was just wondering in terms of what's going on in that space, how does the data look for Māori accessing that?
The data looks consistent with population Mataroa. I would need to probably do a bit more of a deep dive to see what that looked like kind of by locality and you know, access by locality, because I think that given that the service is predominantly based in Palmerston North region, I think there are some issues around equity of access again in our localities, Tararua and Horowhenua. I can do a bit more of analysis in that and share that with the committee if you like.
Sometime in the future, that would be good. Yeah. Just also wondering, like, I see the procurement process to contract Youthline, and I just wondered what access in terms is, what's that looking like for Māori rangatahi, given, you know, that's our biggest part of our population. So if we're going to make some improvements, we really need to target that age group.
Yeah, agreed. And we have been speaking to Youthline about what that looks like for Māori as well.
Yeah. Okay, it'd be good to at some stage get a kōrero about that. Thank you.
Yeah.
Ora matiro, Oriana.
Oh, kia ora, Scott, thank you for that. And I just want to congratulate you on reaching an agreement with about the clinical speciality role based in ED. And I just wondered, will that role also be liaising with the police at any level in terms of you know, the issues around mental health?
I think if it wouldn't initially be a core function in terms of liaising with police, because that probably sits with our crisis resolution service. But if there is anything around kind of broader education around pathways and how mental health liaise and engage with police, you know, particularly around admissions to ED, it would get involved in that respect. Yeah.
That'd be great. Thank you.
Thank you, Matiro. Oriana. Muriel.
Good morning. Thank you, Scott. I just wanted to follow on your comment around workforce on page 3. And whilst I note that most of the directorates have some workforce recruitment challenges to a greater or lesser degree, for this area it appears to be more significant. And whilst you note that coupled with the change program, it's, you know, placing pressure on services. And my question really is about the current staff, and I guess it goes for the whole of the organisation. You know, how are they, and how are we sort of supporting them with such significant vacancies, I guess?
Yeah, it's a very good question, Muriel, and the leadership team, both across the DHB and within mental health, are acutely aware of the challenges that the team face. We as a service are having kind of regular weekly kind of huddles with our teams and our services to check in with them. There's a range of both online resources and we have staff within Te Ururohi who can support staff, you know, from a psychosocial sort of perspective. And we're also needing to make some decisions around how we're managing demand and flow through services. It has meant that in some services, we are carrying wait lists for access, but those wait lists are around no more than 100 people. But we've had to do that, particularly within our adult services.
It's certainly a challenge, isn't it? And, you know, like everything else that's happening at the moment, but thank you for what you're doing. Thank you.
Muriel, Matiro.
Aroha mai, I meant to mention obviously I've done so before, my conflict of interest in being the chair of Emerge Aotearoa.
Matiro. Just a question from the chair, Scott. You know, given the pressures on staffing, how are you managing with patient monitoring and safety?
Well, that's really the key focus around our risk stratification. So we've got very clear risk stratification processes in place so that you know, when referrals come to services, they're obviously triaged through an MDT process. And then we, you know, those people with greatest need are obviously responded to first. So I'm very confident that we have those processes in place, and that we're effectively identifying those people kind of that need our services are still getting the support that they need.
Thank you, Scott. Okay, if there are no further questions, we'll move on. No further questions? Thank you. Lynn, te uru aroto.
Kia ora. I'll take the report as read through you, Chair. There has been some discussion on SBs, and I think the challenge for the hospital is such as system flow across the whole, which includes acute and planned care. We have put in, as you can see, a number of additional initiatives. We have been working closely with the ministry, and we are part of their weekend discharging pilot. We have been successful in receiving, at this stage, we are awaiting the contracts of $2 million to support us with improving our system flow. And I've outlined in the report a number of those initiatives. So we, as of next week, we are looking for one of our senior nurses out of our DNMs will be working as a patient flow coordinator. 3 weeks ago, we started an additional all-day Saturday acute list to reduce the acute surgical demand that was still waiting. Patients were still waiting in beds in hospital on a Monday, and that's seen a significant improvement in that all-day list has been full every single Saturday. So we are working through, we've also got a complex nurse coordinator role out advertising, and that is to support particularly the charge nurses in the complex discharge of patients. And the other, particularly in our emergency department, where you can see our did not waits, particularly for Maori, is a challenge. So we've been working with Tracy and her team, and we are about to advertise for a clinical nurse specialist for Maori and ED. A number of hospitals have that role, an equity role in their emergency departments. And that role will particularly have a challenge, will have a focus on gaining an understanding of access for Maori and accessing emergency care, and particularly the did not waits, and how we can better support and lead some approaches to engage our service there. So a number of things underway. And just as an aside, we've our change rooms have been handed back to us in the first stage of Spire, and I would have to say our staff are thrilled, absolutely thrilled with the change rooms, which is fabulous. They can see the light now, and they're engaged in moving forward with Spire. Our new fluoroscopy machine went live, which means patients don't have to travel now to Wairarapa. And of course, our medical assessment and planning unit in our Adoa and the construction work out the front is on track. Happy to take any questions.
Thank you, Lynn. I was so pleased to read your report. There was some good news. Do we have any questions for Lynn? Vaughan.
Thank you, John, and thank you for the update on the stage 1 of Spire. I'll just go back to my notes. I mentioned that there's some detailed design for stage 2 is on track for completion in February. Can I understand that the stage 2 design's being completed now for the design?
So the detailed design for stage 2 has been completed, and we're just awaiting those costings for. So stage 1 isn't fully complete yet. The change room, the first stage of stage 1, I suppose, is complete. Work is currently underway, continuing in our gastroenterology suite, and for our 4th procedure room in stage 2 will start 1st of July. So far it's planned as we work through. Yep. And okay. Crest, of course, we're working very closely with Crest, and their commissioning of their 5th theatre is underway and is lining up currently at the moment with our progress as well.
Great. Thank you, John.
On. There are no further questions. We'll move on to Uru Whakamauora. Syed? Oh, sorry, Norman.
My hand disappeared there. Then the Saturday all day list, are that people doing overtime, or is it redistribution of people from earlier in the week? I'm talking about staff, obviously.
So currently at the moment, it is actually staff volunteering to do it and are being paid overtime. The ministry is funding that for us at the moment as part of some a funding initiative to support system flow. So that's being funded. So we're just measuring it and seeing how that, I suppose, the outcomes and the measures and the outcomes of that, and if that has a positive impact on bed occupancy on a Monday, on flow through our emergency department and through, but also on less deferment of planned care on a Monday or a Tuesday.
Thank you, Norman. That's a good question. If there are no further questions, I'm sorry, Syed, we'll take your report as read. So it's Lynn and Syed. So I'll take whichever wants to speak to this.
Thank you. Through you, Chair. Look, I'll take the report as read, and I'm not sure if Gabriella's online. Yep. Sorry, I'm not sure I've got all. Oh, there we are. We've got all the squares there. So we'll just take it as read unless anybody, Syed, anything else to add?
Nothing in particular. Happy to take questions.
Thank you. Are there questions for Lynn and Syed on their report? I see no hands raised, so thank you very much.
Oh, I've got one, sorry, John.
Oh, sorry, Vaughan, yes.
Yes, sorry, I'm just playing around. Whoops, you can hear me.
Oh, your picture froze. You're
when
frozen
we had
on
the
one
allied
screen.
services come through, they mentioned that there was a limitation on some of the meeting spaces available in some of our areas, and I just wanted to know whether and appropriate chairs for people to sit. And from what I pictured, that come into some of this area that's overseen in this report. Is that some of those issues? Am I correct in relating them to this department? And are those basic issues being followed up on that were expressed to us? I'm happy to be more specific offline if need be.
It might need to be offline. Sorry, Vaughan, I'm just not sure which area. Was it specifically Star Rehabilitation, a walk around?
Yeah. Sorry, John. I'll follow up this query offline.
Thank you.
Thank you.
Excuse me, Chair, I just had a question. It was just about Garden View, whether there's an update. We're 5 days away from closure, I see.
I can give you an update there. Garden View, actually closed last Friday, a week earlier than planned, and all of the residents were all placed and had moved to their new facilities, so that enabled it to be closed a week earlier.
Thank you, Lynn. Sorry, my screen's frozen, so I didn't see Vaughan's hand. Are there any other questions for Lynn inside? Well, thank you. We'll move on to Kiriro, Debbie, and Kelvin.
Yeah, kia ora katoa, and apologies from Debs, she's away today. But just to highlight a few things, the work with long-term conditions in the background is continuing. The Horowhenua locality service model, I think, is progressing very solidly, and there's been some wider consultations and communications on that just in recent times. Other long-term condition work also continues. I think some non-COVID work, just highlight the launch of the smoke-free 2025 action plan, and there's been some funding, and general health promotion will be happening in and around that, in and around the district as well. And then the fluoridation bill is also just stamping up in the area of public water supply. Everything else, as far as COVID, you'll see is listed. Vaccinations continue, as well as the emphasis on care in the community, which is our big focus currently. Thanks, John. I'll take questions.
Kia ora, Kelvin. Questions for Kelvin? Matiro.
Morena, thank you, Kelvin. I just wanted a couple of things. One is around the smoke-free 2025, and I noticed that there are, a number of things outlined around what needs to be progressed. I just might say that it would be good if the connectivity between public health and iwi Māori providers was strengthened and the relationships were improved, because they're not actually that great. And I think also the fact that Tome is actually the iwi Māori network's contribution to this space, and they do quite a bit of promotion, but there's no connectedness in this report to any of that work that's going on in the Māori communities. So I feel like that's an important missing piece to the puzzle for achieving where we want to go with 2025. So that was my issue about the smoke-free. My second point was that I actually had been approached just this week, and I thought, I'll bring it here, by Kohangareo around the provision of dental services at Kohangareo, and that some discussions had taken place, but no progress had been made. And so I just thought, I'll just bring that, and perhaps then that there's something that could be followed up, because as we know, that's an important matter for Māori tamariki. And when we've seen the data for dental matters pertaining to tamariki, it's quite poor. So Kohangareo are definitely a great space to have the provision of services.
Thanks, Matira. I'll certainly take that back to the team. Thank you.
So Matira, the responsibility for dental sits with Sarah and Jeff, who are on this call. So we might pass that over to Sarah and Jeff to follow up.
Great, thank you.
Kia ora, Matiro. If there are no further questions, I'd just like to acknowledge Kelvin and his team that are at the sharp end of this, and with the bulk of their report on COVID, but I'm relieved and happy to see that you have line of sight over other activities, especially the more controversial one of fluoride. So thank you, Kelvin.
Excuse me, Chair, can I just ask a quick question?
Certainly you can.
I just wanted to know that not everybody is as close to the locality hub setup as some of us might be, and whether, Kelvin, you just had a comment on how you thought they were. I know it's early days and changes every single day, but whether you've got a comment on how you think they're going at the moment.
Yeah, I think certainly Adele's involvement there has been invaluable. How are they working? I think across the district there are some variation. Some of it we perhaps didn't anticipate, others we could have anticipated a little bit better. I think also just there has been, as we've seen with COVID, quite a measure of uncertainty, and I would stress that the teams and the locality hubs have been really amazing in what they're picking up with Oriana. So I'm happy to provide you more details and in and around processes if that's what you would wish for.
Thank you, Kelvin. No, that's really good, just in terms of people knowing what they are exactly. I think they're doing a wonderful job, considering the circumstances they're working under at the moment. So, kia ora, and if you can pass on our thanks to the team, and particularly to Adele and her team.
Kia ora, Oriana, and thank you, Kelvin. Look, public health is one of those areas where no sooner do you address one problem, then another one pops up, which is even more pressing. So it's the never-ending, I think, merry-go-round of meeting health needs as they emerge. And I think the most important part we learned from Kelvin is how critical prevention is, and in particular not only the social distancing and managed isolation that we started off with, but the success of the vaccination program, which could have only been brought through with the great connections that people like Maturo and Oriana have been able to provide through the community with the support of Steve. And so, public health is about us not only holding hands and singing Kumbaya when we feel like it, but actually getting down and doing the hard work. Look, I'd like to put the following resolution that the committee note these areas highlighted on the dashboard and associated commentary. Do I have a mover, please? Thank you, Oriana. Seconder? Thank you, Jenny. Those in favour, raise your hand. Those against? Then the motion's carried. Okay, we'll move on to, we've got our strategic paper at 10 o'clock, so we're running a bit early.
Excuse me, John, can I ask that we move to Scott's paper, the mental health, Maori health equity dashboard, because Scott needs to go and chair the COVID hub meeting.
Okay,
so that will just enable him to get through this before he has to do that.
Right. I just note that David Peel is also waiting, so he's ready when we are.
Oh, okay.
Okay. Well, if you could just advise David, we might be a few minutes after 10. We'll run with Scott now, so Scott can depart.
Oh, it shouldn't take.
Are you ready, Scott?
Shouldn't take us after 10. But
okay. Are you okay, Scott?
Yes, Kia ora, and thank you. I appreciate that. Lot going on in the COVID space. I'm helping out Deb and Calvin at the moment. So yes, look, I'll take the report as read. This is the second report for the mental health and addiction adult health indicators. And you'll see there's just a summary table that looks at the change from June to December. I thought I would note that whilst the doesn't look like there's a substantial change in the indicators, there has been a lot of work ongoing on the ground, both within the primary mental health and addictions area, with the work, particularly between the Mātanga Whaiora and the Kaifaki Puaki Whaiora, the health coaches, the work ongoing there. There's a lot of work happening in the service access space, particularly around the collaborative design work that's ongoing in the Horowhenua locality, which is really working with iwi and kaupapa Maori services to basically design services, particularly in context of the specialist mental health services that we're establishing there, and the work to increase cultural supports within our specialist services with the recruitment of whānau ora and tikanga and cultural competency facilitator positions. Also probably noting the work around community treatment orders and the changes in legislation that's happening, and the detailed analysis that's underway around particularly this area where there is quite a significant inequity between Maori and non-Maori. And I'll take questions, please. Thank you, Chair.
Scott. Thank you. Do we have questions for Scott? Matiro.
Not so much a question, but obviously to also note my conflict of interest is the upoko whakarai for Te Tehi, as mentioned in the report, but also to just acknowledge that there is a lot of work going on in mental health and addiction services across the board. It's a very, very busy landscape. Probably the busiest I've ever seen it.
Kia ora, Mataroa, and I think you know, a lot of it is driven by our change program and our commitment really to address the fundamental inequities that have existed for a long time.
Yeah, so some good work going on. I think that it's, you know, it's taken a long time to get to this position that Scott's saying about inequity, so it's not going to change overnight, but there's certainly a lot of commitment and a lot of work ongoingly to address that. So yes, thank you, Scott, and to all of your team.
Kia ora, thanks, Mataroa.
Kia ora, Matiro. Just an observation, Scott. You know, there are things that have hung around for a long time that are well overdue for change, and one of them is the community, the other CDOs, and how that will be managed. And that's a big change in the provision of service and how we look at mental health. So thank you. Well, I'd just like to, if there are no further questions for Scott.
No, thank you, Chair, and I'll step out at this point just to get myself ready for the up and coming meetings.
Well, I'd just like to note the equity position for each of the indicators, note the analysis, discussion and proposed next steps to improve Māori health equity and further strengthen MidCentral District Health Board's commitment to Te Reti o Waitangi, and to endorse Te Ara Angitu report. Do I have a mover, please? Thank you, Muriel, a seconder. We'll take Stephen Matiro, given your conflict of interest. Okay, those in favour, please raise your hand. Those against? Thank you, the motion is carried. Okay, we have now our presentation. Kia ora, Scott. Okay.
David.
Kia ora, David. I'm John, the chair. The floor is yours.
Thank you. I'm going to try and share my screen. Can you see my slides?
It looks lovely, thank you. Yes.
Okay, so good morning, everybody. My name is David Peel. I'm a radiation oncologist based in Palmerston. I'm speaking to you today from my Hastings clinic. I'd like to talk to you about the Advisory Oncology Service, which is an initiative to offer cross-sectional imaging to the primary care sector. And you got my second slide?
Yes, background.
Yep. So by way of background, 50% of cancers present through standard referral pathways. So for example, if you cough up some blood. If you have some hemoptysis, you'll go through to a respiratory physician. If you have postmenopausal bleeding, you'll go through to a gynecologist and so on. But the remaining 50% often present through non-specific symptoms. And these patients can have quite a convoluted and delayed presentation with the associated physical and psychiatric morbidity. They can go to their GP on numerous occasions, which can get quite frustrating for the GP, who knows there's something wrong, but they don't have the ability to find out what it is. So GPs can feel under-supported by secondary care. So there are a number of models used in Europe, principally in Denmark and in the UK, which set up ways of rapidly diagnosing these patients. And I thought to myself, well, what do I need as a radiation oncologist to be able to treat and diagnose these patients? And the number one non-negotiable is cross-sectional imaging. Until I can see the cancer, I can't treat it at all. And a close second would be histology, a biopsy. So we set up as initially a pilot scheme in August of 2019 to provide support and advice for non-oncological teams in primary care relating to patients where there was a suspected cancer diagnosis, but no clear pathway for their management. And essentially, it enables GPs to request cross-sectional imaging for their patients if they meet very clear criteria. I'll be very specific here. It doesn't replace on-call services for clinical hematology, medical oncology, or radiation oncology. If you've got a cord compression, you need to come in anyway. If you have an existing relationship with the consultant, that carries on. It's for the undiagnosed. And in terms of patient eligibility, I scoured the literature, and these were the criteria we came up with. Unexplained weight loss after history and examination and basic workup, new unexplained pain for at least 4 weeks, together with the suspicion of malignancy, a new palpable mass, or the one I find most interesting is GP gut feeling following 3 repeat consultations with the patient. And this has been shown to be quite predictive, so we included that. Patients who are over 50, previous or current smokers, previous history of cancer, and those who are identified as Maori were thought to have a higher index of suspicion, and so could be referred on for a scan. So there was quite a lot of concern that this would open the floodgates to primary care and they'd overwhelm this, and this emphatically did not happen. GPs are very good gatekeepers. I would argue that patients would have got the scan anyway, except often it would have been during their ED attendance as their condition worsened. And the referral pathway was made very straightforward, with medical imaging accepting the referrals, doing the scan if they met the criteria. I didn't get involved in it at all, really. It bypassed me entirely. The results of the scan are then referred back to the GP, so they own the result of the scan, and they send it through to the appropriate pathway. So if you see a lung cancer, it goes off to the respiratory physicians, for example. But where there was disseminated cancer and it wasn't clear where the primary was, then I'd see them in clinic and I'd talk about a biopsy if it was appropriate. So we ran this as a pilot for 12 months, August 19 to August 20, and there were 30 referrals. 9 of those scans indicated the presence of a cancer, and a 10th that showed liver lesions that required workup anyway. Te Uru Matango governance agreed that this pilot should continue as business as usual. But alongside this, there were continued efforts to publicise the service. I spoke to Fielding Healthcare. I later spoke to Horowhenua. And every time I had a referral coming in, which should have been dealt with in this way, I'd send a nice letter back, and I would let them know that they could have gone through an automated service. Our GP colleagues also picked up on this, and it's now placed on the Primary Care Health Pathways website by Dr. Andy Williams. So it's available to MidCentral and also to Wanganui. So to date, since August 2019, there have been 111 referrals for CT scans. And the majority are women, 69%, The average age for total population is 68, with it being slightly younger for Maori, I suppose representing a younger demographic age structure, and also the index of suspicion, which we highlighted before. And this is the ethnicity data. Now, the overwhelming majority were New Zealand European, and 8% were Maori. In the initial period, of the 30 patients, none were Maori. The second subsequent 30 patients, one was Maori. And so it's really in the latter half that we've started to pick up Maori patients being referred to us. And this follows on from when I spoke to Hora Whenua. You can see the rate of referrals we've been receiving. They're low numbers overall, so you're going to get quite a lot of variability. But I think it's going to settle at around about 5 a month. So it's certainly not going to overwhelm us. Our top 2 referring practices were Fielding, where I spoke to them, and Carey, who picked up on it quite quickly. But a further 14 other practices have been referring patients. And as I say, I feel that the word of the service is getting out there. So, of the 111 referrals, 24 of them have resulted in a cancer diagnosis. That's 21.6%. And compared to international comparisons, that's quite high. Anywhere between 7 and 17 is expected. So I asked myself, do we have a different population? And I don't believe we do. Often these initiatives are done in quite deprived socioeconomic groups, and so you expect to have a relatively high pickup rate. Am I too stringent in the criteria? Well, I don't think we are. I used criteria which were developed elsewhere. And the big one for me is there sufficient GP access? Because unless you can see a GP, you can't get in at all. And to be honest, coming from a UK English healthcare background where access to GPs is free and readily available, to me, this is the big one and is beyond my ability to influence. 20 of the 24 patients were of New Zealand European descent, and so far none of those have been identified as Maori. Our average wait time is 15 days for a CT scan. Now, when I order a scan on Clinical Portal, I can get it in 2 hours, 2 days, or 2 weeks, or 6 weeks. I feel that this is such a high yielding scan that I would like these scans to be done within 2 weeks. And I think the yield justifies that. In terms of cancers detected, the most common one was diffuse metastatic disease. But then there were the usual suspects. Pancreas, which is a deep-seated tumour, very hard to detect otherwise, usually presents in a metastatic format. Lung is common, bowel is common, and a whole smattering of other cancers. Actually, I was expecting to see more metastatic cancers and less treatable cancers. So the GP has this referral back for a cancer, and by and large, they kind of responded very well to it. They didn't drop the ball, and these patients were referred on to the appropriate destination, and that varied from palliative care, medical oncology, surgical referral. As radiation oncologists, we saw about 1/8 of the patients. There's 2 patients where we didn't know where they came from, and we just can't find the data. Maybe the patient wasn't willing or able. I don't know. But generally speaking, GPs are acting upon the results. So, in conclusion, the advisory oncology service is acceptable to GPs, and it's now in use across the district, MidCentral and Wanganui. We need to continue raising awareness to ensure that Maori patients presenting with non-specific symptoms are considered for the pathway if applicable. I would acknowledge that often we are diagnosing metastatic cancers where only palliative treatments are possible. But by diagnosing them slightly earlier, we're giving the patients treatment options which they may not otherwise have. It's far, far preferable to be told about your diagnosis by your GP rather than in the cubicle of ED or after you've been in hospital for a few days. I think it's saving some inpatient admissions. And obviously it gives more time to plan their care around the cancer and inform their family and whānau. So Te Uru Matai Matango will continue to support the delivery of this service. Thank you very much. I'm very happy to take any questions.
Kia ora, David, and thank you. This is a most illuminating presentation. I'll save my comments to last. If you'd like to unshare your screen, we'll get a better view of the questions, but I think Maturo and then Stephen.
Am I unshared?
Yes, you're unshared.
Tēnā koe, David. Thank you very much for the presentation. My name is Matiro Marna. I'm a member of the board. Yeah, it's great to see the initiative and that also it's going to be continuing. I just really wanted to, you sort of made some of these points that in terms of Māori, there already maybe is this deviation to equity issues in terms of the number of Māori who are engaged in the pathway or get access to it. And obviously, I'm not going to comment on it because I know John is much more expert than me about the prevalence of cancer amongst Māori and whether or not there are some early things that could be done. And I'm kind of looking to Tracy and thinking, is this something that could be partnered with Paiora to have a kind of real close look at your initiative, the pilot, and it's now BAU, and get some early kind of pieces in before it gets away on us, because this is what happens, with unintended consequences. So I think the earlier we can do that, like is lowering the age for Māori. I'm not saying it is, I'm just saying, is that a consideration because of our age structure? I just think, Tracy, can you, yeah. Is that something you could help with?
Yeah, Morena, well, you heard David talk about reducing the age anyway, and I think that discussion is continuing. Lisa Te Paiho is all over this, and just for the committee's understanding, anytime any of our leads here speak about anything from a Māori health improvement perspective, we have a partner for everybody within the services in relation to the projects that they're doing. But I'm ecstatic about this one. I think being able to highlight the areas where we need our Māori patients to be better seen earlier, that seems to be the absolute commitment of this program, and I too am delighted that we're continuing with it. Thanks, Matiro.
Great work though, David.
Thank you. I would add that Lisa was able to put me in contact with Hora Whenua. I'm happy to speak to any GP practice that will have me. It's sometimes difficult to combine timetables, but yeah, I'll publicise it wherever.
I wonder if it might be possible through Think Kaora to get on the GP professional education. They run those as Zooms regularly.
What a good idea.
And that way then you could be evangelistic in spreading the word.
I'm very happy to do so, yes.
Thank you, David.
Thanks, Matara. I'll help facilitate that.
Thanks, Calvin.
Stephen and then Heather, and then Norman. Stephen.
Kia ora, David. My name's Stephen Paiwai. I'm the acting chair of the Consumer Council. Mati Draw really covered what I was going to say, but I want to congratulate you on initiating this project, and obviously it was so good it's now business as usual. I wanted to have a look at the ethnicity data, and I guess I could say, oh, that's great. Low number of Maoris in the first, that cancer was detected, none. Oh, well, that's great. But unfortunately, I can't believe it. And it really requires a, closer look, I think, at this. And are we missing Maori? And I'd suggest we are. But it's good to hear what Tracy's saying about Lisa's onto this,
and we'll get some results. So really, I just want to say, you know, thanks for the initiative, and this is obviously, you know, a great start, and you know, I support anything that'll have a closer look at why, you know, how we can get Maori better engaged with our GPs, perhaps. Kia ora, David.
Absolutely.
Thank you, Stephen.
So just to respond to that, the number of Maori referrals thus far has been 9. And so whenever you've got a relatively small numbers, you can get sampling errors. And I'm sure, obviously, though there is cancer out in the Maori population, it's just that within those 9 there wasn't. And I think that's just a sampling error at the moment. I'm sure it'll come, unfortunately.
Heather, and then Norman.
David, thank you very much. And I read this presentation over the weekend and was very excited about it. I'm just wondering, does Te Aho o Te Kahu, the Cancer Control Agency, are they aware of this work? Because they are focusing a lot on equity and also outreach. So has anybody picked that up at a national level through the Cancer Control Agency?
Yes. So, I believe the kind of manager of that service is Kushla Lucas.
Oh, right.
And so and this began in Kushla's time.
Yep.
So she's very, very well aware of it. Yes.
Great, fantastic, thank you.
Can I hear that, Norman?
Yeah, sorry, it wasn't a question. I was just trying those hand signals to clap or put a thumb up.
Look, David, thank you. Look, in another life, I'm also the president of the local branch of the Cancer Society. So it was very satisfying and heartwarming to read your report. But I do share Maturo and Stephen's concerns about Māori. And look, I understand the presentation of cancer is an opportunistic one, and there are several countervailing factors in terms of your study, and you've outlined them. The first is access to primary health care, and probably the most important one is actually wanting to go and get a diagnosis. And I think Oriana sort of earlier on in our meeting outlined the difficulties of people actually trusting health services and being able to engage with them, and some people actually purposefully avoiding them and not trusting them. So I'm not saying this is the picture across the world, but these are some of the challenges you'll face introducing a new program. So please partner up with Te Aho o Te Kahu, but also remember the NGOs are out there to support you as well. And you'll be getting an invitation in the mail soon, and the name will look familiar on the bottom.
All right, yeah. Thank you.
But anyway, I'll stop abusing my my position as chair of this meeting. If there are no further questions, I would like to note the update regarding the Advisory Oncology Service, and I think with much appreciation, David. Do we have a mover, please? Thank you, Heather. Seconded by Stephen. Those in favour, raise your hand, please. Thank you. The motion is carried. We'll now have a short break. We will return at 10:30, and for those who are veterans of these meetings, this is probably the first time I've ever been on time. We'll see you again at 10:30.
On top of that, you'll have noted the 2 reports for Te Ara Angitu this month. That work is still progressing really well, and we are working in partnership to make sure that the planning for what the actions are that need to be taken inside of those services from an equity perspective are well understood and well resourced. We are also establishing, as Lynn said in her report, an equity role into ED. So that's a piece of work that we're just looking into right now. We have the job description all ready to go. We're just working with Selena on making sure it's the right role given the issues that we're identifying in ED. So if you were doing a helicopter view over hospital and specialist services as a committee, what you'd start to see is a mapping of Māori health services across all services, partnered by particular specialist positions or people, should I say, and ED is the last component of that. So we're pretty excited about formalising what that picture looks like to make it easier going into the reforms to help people understand that. Rongoa services is being discussed for hospital, and we're pretty excited by this because He Puna Hauora has good relationships internally, and they are starting in Ward 21, but ideally what we would like to do alongside of the 4 services that we have established into communities with the equity funding that the board provided last year is to be able to provide services inside of hospital for our inpatients as well. You can see that our 2 FTE that have been working with these patients internally have engaged 2,777 patients in the last year. That's a pretty good engagement with patients, and we are expecting, as I say, to fill another 2 FTE to be able to support this team because those numbers are growing. We don't just stay in hospital working with these patients, we actually follow them back out to make sure that they're either engaged in a community service or a warm handover into their primary care service. Now, what we are identifying is some of our patients aren't enrolled into GP practices, and I think we all know why that is. So we're just making sure that they, at the very least, have a community provider to support them. We have been cleaning up our contracts, ready for the transition. So yesterday was the last day for all planning and integration leads to complete this, to do this cleanup of contracts. It was very exciting to see the changed contract, particularly for Rangitani or Manawatu. This is a bulk funded contract now with less reporting and more outcomes-based reporting based on the work that was done by strategy planning and performance, signed off by, endorsed by Mana Whenua last year in November, and then board in December. The contract looks pretty good, I must say myself, and so I think moving into either Māori Health Authority or Health NZ, I think they're going to be happy with the way in which we've cleaned those contracts up, thanks to Adele. And then just going into growing the workforce, there's a lot of emphasis going on in here at the moment. In fact, we had a small whakatau this morning because of COVID, the COVID environment for Tūpotahi Maniapoto, who is coming in as a direct report to Adele to support the Te Ara Angitu work. So ideally what we'll have is an equity analyst that looks into all of these areas of poor performance in terms of the indicators that are chosen by Mana Whenua Hauora. That role is yet to be recruited to, and 2 will come in and set up the projects and support in partnership with the directorates where they find those issues and need for particular projects of work. So he's going to get started on the indicators that we already have and just get to meet the teams around the traps and understand what the current Te Ara Angitu actions are for each of those indicator areas. And then on top of that, very proud to say, I've got it wrong in the report, sorry, the 55 new Māori staff is not in the last 12 months, but the last quarter. So that's pretty exciting. And when you look at the breakdown of that, they're not just our unregulated staff. We've got 23 of those 55 people are actually clinicians, doctors and nurses. So really good work going on in the Māori workforce space, and we've got formalised relationships now with the Pūhoro STEM Academy, with CEDA, and more recently the Māori Education Trust, who are providing us with 40% of the scholarships that we provide as a DHB going forward. So that gives us more resource to be able to put into scholarships. We have 31 applicants sitting right now. 18 of those are student, eight of those are postgrad individuals, and we even have social workers coming through. So all very exciting. Whakapapa to this area, are very committed to studying, and we have a Tuakana Taina program which we established last month, where every one of these students will be teamed up with somebody more senior to support them in their areas of study. So and two are engaging in the midwifery space for study. So we're very delighted with that. We don't want to lose those 2. And so I've given you a more detailed understanding about the Kaimahi Ora Whānau Water Implementation Program as part of the report for your information. So from there, I'll take any questions. Thank you.
Got it, Tracy. I'll save mine till last. Do we have questions for Tracy? Stephen and then Vaughan.
Tēnā koe te tuahine, Tracy. Look, congratulations to you and your team. Really, a couple of comments. I think I've got some questions there, but the first thing I read was the 55 staff in the last year and 10% of the workforce. I think that's the highest I've ever seen. But then you tell me it's in the last quarter. Well, that's absolutely brilliant. And I guess it shows a couple of things. MidCentral is obviously a great place to work. Or a lot of work's been done in that space to recruit those new staff, and particularly 23 clinicians, I think you said. So
that's right.
Well done to everyone there. The scholarships, I read there. Did I read there that you had nine applicants, or did I read that wrong? That was a because long term, I think that's where we need to be, identifying our young and encouraging them into a health career, because as we know, there's plenty of opportunities there. I just want to comment on the work that's been done about rongoa. I've been involved in health governance for a while. This is pretty new to me, and Ward 21 was it that trialing that. That's huge steps. When I first came into health, they would, this would have been treated with skepticism, I guess. So we've come a long way. And I just wanted to ask, I read somewhere in your report about trialing after hours service and what that might involve. So a bit about scholarship, a bit more about scholarships and the after hours service, but overall great report and well done to you and your team.
Thank you, Matua. I think first thing I would say is that at the time of writing this report, our scholarships were still open, and didn't close until Sunday. All the analysis has been done, and that's why I'm able to give you the numbers, including the 31 applications versus the 9. The push was because we had a lot of media interest, and so I did an interview on Te Karere and on Radio Maori FM and a couple of other areas like the MidCentral DHB website, and out to our iwi and Māori providers who also put it on their website. So that's why we've had the increase. And I'm quite happy with the response of 31 applicants for first time round for this organisation of a scholarship like this. So OLT was pretty proud of it on Monday as well. And just looking at the 55 new staff for that quarter, what I can say from January is we've also had another 20 Māori who have started just in the month of January. So I think there's been a real shift in the organisation to understand the need for it. There's a real clear understanding about what we're trying to achieve. And our hiring managers are getting it. They actually understand why we need more people in this space. And certainly all of our executives are backing this program. So it certainly helps with them being on the governance group for this work. So the month of January, we've got 2 allied health staff, 2 new nurses. We stole one from Hawke's Bay, but don't tell anybody. 7 medical staff. Those are our PGY ones who have come through, and administration and management, we've had 4 in that space just in the January period. So they're moving into the rongoa space. I think, yes, that's certainly been a long-standing view of this district, wanting to see contracts in place. The ministry had been providing contracts external to this district. Not sure why we don't have the whakapapa to that. However, because we had that equity fund, we just decided to kick in and establish our own services using the same contract specification that the ministry did. We've notified them and they're happy with that, so they're happy to engage the contract owners in any training or anything that they're delivering on top of what they're doing currently with existing contracts. And then just going to your last point, sorry, Matua, I've forgotten what it was.
Did I read trialling after hours service? I'm not.
That's right. That's right. Yes. So, so what we've noticed over the last few years is because we haven't had any new resource until now, we've just done with what we have, and so we've had people like Doug Edwards and Wayne Blissett and Tracy Haddon, who have largely just taken the phone calls from our staff within the organisation, purely because the relationships are strong and they know what one another does. What we want to do now is formalise that so that our staff have some ability to be able to engage with Pai Ora up to 11 p.m. at night and on weekends. So that's the work that we're doing right now with HR to make sure that we are rostering people on safely and appropriately, and making sure that we have got the right supports that we need for each of the services, more particularly ED and the death and dying pathway is where we're most are excited that we're starting that piece of work, because that can get quite difficult for our whānau in the hospital when they're working in those times, trying to deal with the clinical matters of patients as well as those social and spiritual needs.
Kia ora pā. Vaughan and then Matiroa.
Kia ora, Chair. Thank you, John. Thank you, Tracy. Just again, Stephen was asking around that scholarship program. I too was interested in that. Can I understand the value that each recipient would get? Is there a dollar value that we contribute to that?
No, because they're all assessed differently. They're assessed by a panel that then pushes that up to the senior executive of the areas in which they want to study, who then endorse their study, and then it goes to Kaya and I for the approval of the amounts that we're going to attach.
Okay, is there a pool of funds that we can allocate towards that? Can I understand? Yeah?
That's right. So if you remember last year through the equity funding, what we've done is we've associated 200K of the $5.8 million for equity into Māori workforce development. And of the 200K, we have established a budget of $40,000 per annum for scholarships.
Great. Thank you. That's been a great outcome in the end. And I just wish we'd started it a few years earlier.
So do I, especially in the space of midwifery. But what's exciting is that the Māori Education Trust have seen that this is probably a winner program, and that's why they've agreed to provide us with 40% of whatever we establish as scholarships. So that's going to help us be able to put more into the back pockets of these students. We've got one, I don't mind sharing this with this committee, we've got one applicant who is a solo mum of 2 children and has just lost her mother, who has another 4 children at home, and she is now having to look after those children as well. So 6 children being looked after by a 29-year-old woman who wants to become a nurse is just amazing. So it's very important this Tuakana Taina program is wrapped around each of these students so they succeed.
Yeah, thank you. Thank you, Chair.
Matiroa.
Morena, Tracy. Thank you very much for the report. And I just wanted to make just a comment to acknowledge that Tracy recently had been sitting at the table on behalf of the DHB for the development of a prototype that was submitted to the Transitional Health Unit between the partners of Mana Whenua, Think Haora and the DHB. And as a part of that prototype, which we have yet to hear the final outcome of, is the establishment of Maori Ora. So Oriana can probably comment more, but pretty much Mana Whenua becomes its own entity and then has a backbone organisation called Placeholder Maori Ora. And I wanted to touch on that and just wonder how we might support, or how the DHB might be able to support the establishment of Maori Ora, or whether or not that is something to be considered at this space and time.
I did write a little bit about that development under number 5, enabling iwi and Māori to reach Pai Ora. I probably need to hand that over to you, Kath, in terms of the DHB's support of those developments, iwi partnership support and Maori order.
I'm sorry, I was just doing an urgent COVID matter, so we
sorry.
can talk outside of this meeting.
Okay, Te Pai Matiro.
Sorry, I missed. I heard Tracy say she's going to hand it over, and I'm not sure where we got to.
Let's take it out of the meeting, and we can have a conversation outside of the meeting.
Okay, that'd be good, because I guess it is just part of that transition and where the opportunity lies, and at some stage having the board a part of that. Ngā mihi.
Might be a good conversation to have with Brendan also.
Look, if there are no further questions, okay, right, my whole screen's rearranged itself. Look, thank you, Kaya. Look, it's the progress you've made is fabulous, and as Stephen observed, in the last quarter to have 55 FTEs recruited is extraordinary. We hope you can keep it up. But look, just to think back, look, the Maori Education Foundation, one of the great stalwarts of that was Sir John Bennett, and to have the Maori Education Trust now involved in this is wonderful. It has a huge whakapapa. But we also must acknowledge the contribution that Shane Riuwhiu made with Whakatūtuki Moimoia. So look, this is wonderful progress on a kaupapa that has a long whakapapa to it. So kia ora, Tracy, and thank you very much. Okay, well, if there are no further questions, we'll note the progress update on Paiaka Whaiora Māori Health Director. Do I have a mover, please? Kia ora, Heather, and thank you, Stephen. Those in favour, raise your hand. The motion's carried. Thank you. We'll move on to Enable New Zealand now. Thank you, Michelle. Sorry for keeping you waiting.
Kia ora, morena, everyone. I'll start again, morena. I've got a lot going on in my household at the moment, but just in terms of this report, it's been a reasonably straightforward 3 months for Enable New Zealand. One of the and it's straightforward in that we've achieved all of our set kind of performance targets. However, in terms of stats and figures, I thought I would draw your attention to some of the changes that have gone on. Unfortunately, we haven't got October's results in here, and so it doesn't really show the great big lift in numbers that we've had. So typically in the month of December, we would do somewhere around 7,000 pieces of equipment. But of course, this December, you're seeing the figures with emeries included. So our numbers are significantly up. We estimate on for this month that we're doing around an additional 7,000 pieces of equipment for the month, and that our expenditure has gone up to around an additional 3 million per month just on ACC's equipment alone. So it's really, we're tracking that, we're keeping on top of it, making sure that we're doing as much as we can, but it's certainly for this forum putting a significant amount of pressure on the team, particularly when we think about supply chain issues, cost of petrol, trying to find couriers that will pick up equipment and deliver equipment on our behalf has been very challenging. And in addition to that, finding staff is probably our biggest challenge. So as part of our bid, we estimated that we'd need an additional 35 staff, all funded, of course, through the contract. We've only been able to recruit 20 so far. So a lot of work is going on at the moment to try and address the large numbers that are coming through and are waiting. We're working really closely, as an example, with both ACC and the Ministry to remove some of the pressures namely approvals that we have to go through to issue a piece of equipment. The intention being that with COVID also nearing and big absences of staff potentially, that it's going to get tougher and harder for Enable. So we're trying to work through a really detailed plan to make sure that we can still provide a continuity of service. To date, both ACC and the Ministry have been really open to changing the way we work to make that happen faster. Ultimately, I think our intention is to try and keep those reduced measures in place, or those reduced checks in place, because it does speed up our service and reduces some of the handling. Overall, though, I'm really happy with our result, despite the challenges that we've been facing, and I'm looking forward to reducing some of the backlog. Are there any questions for me?
Go to Michelle. Do we have questions for Michelle? Well, Michelle, I think that's 3 in a row we haven't had any questions for you.
That's okay.
I think you get a chocolate fish now.
That would be lovely.
Michelle, we had a really great meeting with the CEO of ACC, didn't we?
Oh, yes, we did.
Some good outcomes.
Yes, we did. So as part of our, well, there's a new chief executive for ACC, Megan Main is her name, and as part of her induction, they arranged a number of stakeholder meetings with key stakeholders for ACC, and Enable, thankfully, we're lucky enough to be chosen to meet with her. And so Kath and I met with her over Zoom. It was a really, really good meeting from my perspective. We were able to, thanks to some of the guidance from Kath, we did a quick presentation on how wonderful Enable is. It's really easy to be when you're really proud of the work that you do. So she already knows Enable New Zealand. She'd been up here and visited in a previous role. But in amongst that, I talked about the BCP framework that Enable had developed to respond to COVID, and how we wanted to remove a number of the approvals and increase the thresholds for approval to get the service streamlined. And as a result of that meeting, she went back to her staff afterwards and said, "You're not doing it as a BCP, it's going to be standard practice, make it happen." So we were pushing and meeting a little bit of resistance prior to that. So it felt really good to have the chief executive on our side and making things happen, hopefully. I will say ACC is like a giant ship though, and when the captain says the ship needs to turn, it takes a little while for it to happen. So we're still waiting.
There are no questions. Thank you, Kat. If there are no questions for Michelle, just to note that the quality you're reporting is reassuring, but I think that it's also reflected in the quick rapport that you're able to develop with the Chief Executive, new CEO of ACC, that you were trusted enough in terms of your ability to deliver that she could with confidence instruct her managers to listen more carefully to what you have to say. Whether they act is another thing. Thank you again.
Thank you.
Well, I'd like to move that we endorse the Enable New Zealand report for the 31st of December 21. Do I have a mover, please?
Yeah.
Thank you,
Michelle.
Ngā mihi.
Ngā mihi.
My screen is kia ora mataura, but my screen is frozen. Oh, everyone's moved now. Could anyone put up their hand who did not disagree with that motion? Okay, I'll move the motion as carried. Thank you. Equality and safety. Kia ora, Michelle. I think back to your children. On to the next item on the agenda, 5.3, the Quality and Safety Dashboard. Gabriel. Are you ready, Gabriel?
Yes, just a little knock at the door, always just divert your attention for a sec. This report, it's my first opportunity to present this report, so I'm learning as we speak. The committee will note that this particular period has been impacted a little bit on the holiday period. You'll see high number of correspondence from HDC as they're clearing their desk for their stand down period. We received quite a bit of activity at the end of November, beginning of December. And also in response, our response times have been a little more extended due to that period of closure. And there's been an increase in pressure care incidents, and some of that is in relation to the high turnover in some of our wards and our ability to keep up the training in those areas. But happy to take questions, and I'll do my best to answer them.
Thank you, Gabriel. Do we have questions for Gabriel? Jenny.
Right. Morena Gabriel. My question just pertains to the complaints, and I just wondered, because certainly the report speaks to the number and the slight reduction, and I guess we can see that in the graph anyway, but there's nowhere in the narrative that identifies any common theme, either by what department these complaints come from or common theme of complaint type. And that would probably be more useful dialogue to me than just reiterating what I can see on the graph.
Yeah, and we've talked about that, Jenny, and a lot of it is coming from the waiting room pressure in ED.
Okay.
That is the majority of the complaints. And great feedback once our consumers get through the doors, but it is the waiting for and the delays that they feel in waiting room and ED.
Not excellent scenario, but excellent information. So that's exactly what I was after. Thanks for that.
Muriel.
Thank you, John. Thank you for the report, Gabriel, and I appreciate this is the first time you have presented this, but just a couple of things. First one is great to see the ongoing improvement in hand hygiene. That's a really good result because that's always been a challenging area for us. You mentioned the pressure injuries, and that is quite a significant area of concern. And I guess even, whilst we can't necessarily resolve the non-hospital acquired pressure injuries, I guess we do have some responsibility in terms of looking at what we might be able to do to support, for example, residential care, if that's where these people are coming from. But also a comment about the pressure injuries in hospital and the fact that you say some of that's due to high turnover. But I also wonder if we've always struggled in the past with the specialised equipment required for helping to prevent pressure injuries. Whilst it's not the only solution, it's part of it. And just wondered if we still have challenges around that and whether some investment needs to be made into that specialised equipment.
That's a good point, Muriel. The mattress, the bariatric working group and the pressure care group have both reviewed all the mattress requirements, and it's an ongoing procurement process. So if I had Desley in the room, she would say they have turned and removed considerable amount of mattresses from the stock and replaced them with new mattresses. That's an ongoing process. I think with the pressure care, our nursing team are very acute at looking for pressure care, whether it's a reddened area or where it's unstageable. So there's a whole spectrum of incidents that they report. And with some of the dependencies, the complexities of our consumers in the last few months, with high delirium rates, there is our people are not as well coming into hospital, and they're more dependent, or they've taken time to get into hospital. So at those times they bring some pressure areas with them. And it can be a matter, as you know, a matter of 2 hours between a reddened area and a broken down area. Yeah. So our equipment, I feel confident that the team have got that in hand. Huge mattress replacement projects ongoing. And where I reflected the staff turnover in some of the wards, that's just the nature of bringing on new staff and having educators to be able to do that. Some of our educators are sitting in the COVID space at the moment as well.
Yeah, and so that turnover really is about a certain amount of loss of expertise around this area of specialty.
Yes, and remediating that, they're having the wound care and pressure care team are having subject matter experts trained for each ward. So they become the resource on the ward at the time. So that's a work in progress at the moment.
Okay, thank you, Gabriel.
Stephen.
Yes, thanks, Chair, and well, thanks, Muriel, for reminding me. I've got in my notes about hand hygiene. I can remember, and some of you might remember, about probably 3 years ago, as acting chair of the Consumer Council at the time, in a 6-monthly report to the board, I raised hand hygiene. We as a council were somewhat shocked. I think back at that stage it was down about 50 to 60%. Some of you might remember that, and now, do I recall, it's about 86%. Now, obviously COVID's got a bit to do with that, but I just wondered, Gabriel, if that can be acknowledged, that that huge increase, that we need to congratulate staff, changing that habit, turning that around. So that was my comment. Thanks, Chair.
Well, thank you, Stephen. Yes, it's the challenge is to be able to maintain that high percentage, but I think the charge nurses know they get their monthly reports on hand hygiene and they'll feel very proud of those results.
Kia ora, Stephen.
COVID
well, if there are no...
can be thanked for that, a lot of that, I suspect.
It's again, it's another kaupapa that has a long whakapapa to it, Muriel. and thank you, Stephen, for reminding us of that. If there are no further questions, I'd like to endorse the improvement activities planned for the next quarter. Do I have a mover, please? Thank you, Jenny. Seconded, Muriel. Those in favour, please keep your hands up. Okay, the motion is carried. Thank you very much. Kaya, we're quick dashing on to the discussion papers and Māori Health Equity Dashboard. And Kaya, the floor is yours.
Kia ora, John, kia ora everyone, Morena. Just picking up on the paper on Māori workforce indicators that were identified as part of our plan. The paper that I've provided looks at 3 key areas. One is obviously increasing Māori representation in the workplace, having work practices that are inclusive and sensitive, and the third one being staff training and cultural responsiveness in terms of staff being trained. So the dashboard talks about it. I think the last few months have been challenging to say the least. I mean, with implementing the vaccination orders and staff losing staff to not only the turnover but an increased, that turnover got kind of exacerbated by that, by the impact of that. Although minimal when you look at the big thing, but it did have some impact on staff leaving, as we all know, and as through the reports that I have provided. So that said, we continue to make slow but steady progress on that, and I must admit the work that is being done through Paiora, through the Senior Maori Workforce Development Officer, has been absolutely stunning. She has taken a very, very active role in her job as trying to promote MidCentral as a place of work, as well as supporting and promoting Maori within the workplace. And I must give credit where it's due, and I think she is partly and fully responsible, quite in a lot of ways, in promoting workforce, many of these workforce initiatives through this. We've got the Treaty of Waitangi and the cultural responsiveness program, but what we've been discussing about is having some kind of a more support network in terms of training programs. And there's some training programs that are available at no cost within the public sector that we can leverage off. And at the moment, the Paiora team is considering the cultural appropriateness of where and how this can be fit into, whether we fit it into the orientation induction process or we fit it into a pre-Treaty of Waitangi training process. It's just about understanding where it best fits. And once it does that, then we can introduce these programs because they are available and it comes at no cost. The thing is that staff, once they do these kind of training programs and they participate in this training, they are quite engaged. And the overall responsiveness, the response from staff is that they want to continue to have this kind of training going forward. So it's all a win-win. We just want to make sure that we can get some of these programs to support staff as we go along. So I'll probably stop there. Obviously, you might have heard a lot about the scholarships, and I'll probably lean on Tracy to help if at all your questions are directed in that direction. So I'm happy to take any questions.
Thank you, Kaya. Are there questions for Kaya? Observations? Well, from the chair, I'd just like to thank you, Kaya, for your report and note that it's policies like this which will reassure the 55 new FTEs that have been attracted into MidCentral, that we have policies in place to support the training that they've done and the world that they bring into the District Health Board and whatever follows. So thank you. Stephen, I noticed you had your hand up briefly.
No, it was, sorry, it was just a reaction. I completely agree with you. Thumbs up.
Well, thumbs up.
Yeah.
Thank you. Well, if there are no further questions or thumbs up, I'd just like to note the progress made with workforce indicators identified in the 21-22 year, and note the analysis, discussion and proposed next steps to improve the current workforce indicators. Do I have a mover, please? Thank you, Stephen. Seconded by Lou. Those in favour, put your hands up, please. Thank you. The motion's carried. Okay, on to the information papers, Regional Services Plan. Angela.
Thank you, everybody. I'm off. Thank you.
Oh, thank you, Kaya. Thank you very much. How rude of me, dashing on like that.
Okay, so kia ora koutou. So I've got the next two papers, I think, on the agenda. The first one being the Regional Services Plan Implementation Q1 and 2 report for the 21-22 year. This report is something that TAS prepares and submits on behalf of the 6 Central Region DHBs. So I'll take it as read and I guess just highlight the key points of note from that report, which were that there's no requirement to present a regional services plan to the Minister of Health for this year. As I said, TAS prepares this report on behalf of the 6 Central Region DHB, so they have carried on with having a plan. The single system of care and mental health and addiction programs were deferred between November 2021 and January 2022, but they now have 2 FTE program managers in place to progress both of those programs. And as is probably no surprise, a key focus for the Central Region during this period has been on progressing the Regional Resilience Program and supporting the region with planning for Omicron. So that's really all I have to say about that particular report.
The report that we don't have to forward. Thank you, Angela.
Yeah.
Are there questions for Angela? Well, thank you, Angela. Look, it will go to the board as such, but it's a shame that the ministry doesn't want to know this good news.
Sorry, John, Chair, can I just make a comment? It's not a question for Angela, it's just a comment around Regional Services Plan and TAS, just to let people know that TAS has appointed Joanne Hayes as the mana whenua representative to their board. I'm just looking at one of the points in Angela's around building regional relationships.
I didn't see that.
It's not a part of this report per se, but it does. It will impact on the regional service planning going forward, that we do have someone in a governance role.
Oh, kia ora, Oriana. That's helpful. Okay, if there are no further questions or comments, please note, I'll move to note that there is no required to have the Regional Services Plan presented to the Minister of Health for the for 21 progress made on implementing several priority programs for quarter 1 and quarter 2 for 21-22. I have a mover, please. Thank you, Meryl. Seconder. Thank you, Karen. Those in favour? Thank you. The motion's passed. On to Angela and again our locality progress report for the Manawatu.
Okay, so again, I'll take the paper as read and just highlight a couple of things within it. The plans that were developed back in 2018-19, that plan had 53 actions in it. We've added 10 since then, and 61 of those 63 actions are either completed or progressing well. And you'll see at the back of the report, there is a summary of that. But some examples I've highlighted of progress that are being made in those community priority areas. So obviously in access to healthcare, I think the provision of vaccinations in different ways has been really successful and a huge factor in achieving the great vaccination rate in the Manawatu district. So, the clinics outside of regular hours, the by Māori for Māori approach, the going to where people are already gathering and having the drive-through options, I think are all good examples of doing things differently to break down barriers to accessing services. And I think going forward, and I have actually seen this in some of the other workshops that I've been in recently, some of the learnings we can take from that provision going forward into other services will be great. And another example of improving access to healthcare is, you'll notice I've put some bullet points of Dr. Philip Suerstedt, who delivers the clinics in Fielding, the gynecology obstetrics clinics. And he said he's definitely noticed attendance is better. Patients are commenting about the ease and convenience. Many walk to the clinic. There's a lot of appreciation for the free parking. And also things like being able to walk them to the lab to schedule, glucose blood tests and things, where otherwise, you're not necessarily knowing whether that link has happened or not, has been really good for there. So, a lot of good points he's highlighted there from providing those local clinics over in Fielding. Another one highlighted in the mental health and addiction space is the role of the health coaches within that community. So there's 2 health coaches in the Manawatu district, the Kaipakapuaki Waiora, so they're part of the Te Araro primary mental health program. So they are based out of Ngā Kaitiaki o Ngāti Kaupata and Waiora Trust over there. So they provide their non-clinical roles who walk alongside whānau with mental health addictions or other wellbeing challenges and support them to manage what they're doing and help them to reach their goals and aspirations. And obviously that's a free service, which also makes a big difference. And the final couple of things I've highlighted there in the wider determinants of health for the healthy living priority area is a program that, again, Ngā Kaitiaki o Ngāti Kaupata have been undertaking to improve the health of homes for Māori whānau in Fielding. They've upgraded 25 and have a list ready for the next tranche. They get funding through TPK to do that. And something that was raised recently, the local work and income office, they're represented on our health and wellbeing group over there, and they're doing a project where they're going through and ensuring that all of their clients who or they're working with clients and the local GP teams to ensure that all those people who are eligible for a disability allowance are accessing it, because they were finding that they had a number of clients who were entitled to it who weren't accessing it, and particularly Māori that was relevant for. Issues that have been raised recently, I've highlighted a few there. Again, we try and meet with the local iwi in each locality relatively regularly. And Ngā Kaitiaki o Ngāti Kaupata highlighted growing incidents of family harm, which they think are exacerbated by the pressure created through COVID-19, waiting times for health services, access to warm, affordable housing, and rangatahi not being engaged in education and not having a local provider of alternative education were the 4 things they highlighted when I met with them in December. At a recent meeting, a recent hui in February, they also added, you know, the mental health space. They're still find they've got a lot of people who are not knowing how to access clinicians. So that's an area that we're still, you know, still working on. We went to the farmers market last year, but we certainly, the demographic that we spoke to there were primarily older adults, and it was really evident that COVID was definitely the focus, and most of the points that came out of that were COVID related. And I guess finally, the last thing to highlight, I have just noted some of the things, so I guess those issues were raised, some of the things that are being done in those spaces. So, you know, kōwhatu raised family harm, growing incidents. Within the DHB, there's been a family protection team established. Will hopefully, you know, make a positive contribution to preventing family harm and child abuse within our rohi. Fielding, I've also mentioned Fielding Healthcare's trying to expand their primary care options. So they've just offered a new service recently, a virtual after hours GP consultation service that people can potentially choose if it, you know, if it suits them. And then the other ones are probably things you're well aware of that we're trying to do as a DHB. And upcoming work in the next 6 months, continuing the community engagement and communications out into the community, trying to provide, I guess, more information about, again, how to access things and also good things that are happening in the community with our communications. But work I'm just started doing at the moment is on refreshing the demographic profiles, and particularly want to provide more information about the projected populations. So we've recently received some data through, we've asked Infometrics to do a project looking at our projected populations, breaking it down by TLA area and DHB. And so I'm looking at incorporating that into new population profiles that will hopefully be useful for planning going forward. Are there any questions?
Got it, Angela. Any questions for Angela? Well, thank you. It's really nice to have a heads up on the localities and the concerns coming back from community groups like kōwhata, but also the development of services and fielding as well. So thank you. Would Malt, sorry, Tracy, would Malt be able to help out in terms of just linking these various community concerns with the government agencies?
You mean the RIN?
Oh, RIN, sorry, yes, sorry, yeah.
Yes, so Ange is my partner in RIN, so these issues are being taken to RIN, and what we're doing is developing a plan as we speak.
Thank you. That's lovely. We have a hand up somewhere. I can't. Vaughan.
Yeah, thank you, John. I'm happy to just say it's not so much a question. I was just really making some comment around this focus of reducing wait times in ED, and yet they continue to rise, as mentioned in this report, and went back to the directorate report just to, I guess, nail down some of the initiatives, and some of these new initiatives to bring the numbers down. I've only just started in early February, and I guess a disappointment for my mind, just knowing how challenging it is one of the objectives I wanted to achieve coming onto this board, is knowing that the wait times in ED had a lot of pressure on, and yet coming to, like you say, our second to last meeting of this term and finding that they're only but increasing. I just find so gutting that whatever initiatives we're putting in place just don't seem to be working. So, as effectively as I would have wished, but just highlighting just how important ED is to us in getting care to patients. But if they're waiting so long, they don't even wait to be seen as a concern. I just wanted to re-highlight. Thank you, Chair.
I think through you, Chair, if I can, Vaughan, the key things that we have happening at the moment that will make a difference is the SPIRE project, which will establish not only additional access for planned care, but additional bed capacity. And then the EDOA and NAPU building that's happening next to the ED. Those will have the single biggest impact together on ED wait times than any other thing we can do. The issue is we simply don't have enough capacity for the volume of people attending the ED and being admitted into our hospital space. We run constantly over 100% occupancy in our medical and surgical beds.
Yeah, and I guess in response to that, again, thank you, Kath, is again, these have been not unknown issues, and yet the funding for our capital investment is been only part of what the solution needs to be. So I guess, again, a cry out to advocacy to central government to actually be investing in the health facilities that are, beyond fit for purpose. So that's, I guess, the point that I ultimately come up to is central government need to kind of get their heads around a significant investment into health and the critical areas around emergency departments and the capacity and resource to personnel those. Thank you.
Kia ora, Vaughan. Heather.
Thank you for the report, and I'm really just picking up on what you've said, Vaughan and Kath, because I think the other thing about ED is the inaccessibility of primary health to people. And what I'm reading in this locality report is a vamping up an attempt to increase access and make primary health initiatives much more accessible. So, ringing in my ears is what David said before. In the NHI system, GPs are free. I don't know what impact that has, but they sure as hell aren't free in this region. And that, the wait times to get into GPs, the lack of adequate GP numbers, it creates a bottleneck in the wrong place, in my view. And so I applaud these initiatives at locality region. Obviously, they are just going to take a long time to get traction and reduce that, trying to fit square pegs in round holes, getting too many people into ED because they haven't had adequate community or primary health support. So I hope the new environment is really picking that message up loud and clear too, because we can't all be on campus, be seen to be on hospital campus problem. It isn't. I mean, sure it is in some aspects in terms of facilities and capacity and resource, but also it's what's coming in. Why isn't it being averted before it gets to the hospital door? Just a comment, I don't expect anybody to have the magic answer, except I think these locality initiatives are the beginning of that.
Kia ora, Heather. I think you've voiced what we're feeling anyway, so thank you. If there are no further questions, I'd like to note progress being made on the relationship to Manawatu Te Mahere Hau Order, that's our health and wellbeing plan. Do I have a mover, please? Thank you, Vaughan. Seconder, thank you, Jenny. Those in favour, hold your hand up. Thank you, the motion's carried. Okay, and last thing on our agenda is our work programme. Look at it carefully, it's about to disappear. Are there any discussion on our work programme before I'll take it as read? Thank you. Well, I'll just note the update on our Health and Disability Committee work programme. Have a mover, please. Thank you, Jenny. Thank you, Muriel. Those in favour, keep your hand up. Motion's passed. Thank you. Okay, well, our next meeting is on the, Tuesday the 24th. We will address the remaining items on our work programme. And I'll now move to the exclusion of public, that the public be excluded from this meeting in accordance with the Official Information Act of 1992 for Section 9 of the following items and reasons as stated. Do I have a mover, please? Thank you, Muriel. Seconded, Jenny. Thank you. Those in favour, please raise your hand. Thank you very much. So the motion's passed. We will now move into part 2. This meeting finished at 11:28.